One. All right. Good morning, everyone. Welcome. This is BIO117. Some quick announcements. We have a quiz Wednesday, and that will be on chapter 17 and 18, 8 a.m. promptly. Next week, of course, is break. I haven't gotten approval yet, but I'm probably going to be available Monday and Tuesday that week for any tutoring. But after that, I'm on vacation like you guys. Bunch of course today, 12 to 1. We have two quite hefty lectures today. Respiratory and renal. These are not easy topics, and they're quite full. So today we're going to try to end up at 3 o'clock. So at 3 o'clock, we'll start working on what's our nice questions for 17 and 18, and then of course at time we're going to start delving into chapter 19, 20. So with that being said, I'm going to have the timer so I can be a little bit more efficient today. So chapter 19. We're talking about the respiratory system. We already know the definition of respiration. It's gas exchange of oxygen and carbon dioxide. And that can happen at the lung level, of course. When you breathe, when you inhale oxygen. And when you exhale carbon dioxide. We also know when we study the mitochondria, we can see it also at the cellular level. Oxygen goes where? Into the cell, right? And then what comes out of the cell? ATP and carbon dioxide. So that's actually what respiration is. It's gas exchange. Another thing that the respiratory system does, other than gas exchange, is, remember we always talked about everything on the inside has to be moist. It can't be dry, nor it can be wet. So along with body temperature and the very fact that we're breathing and air has some water vapor in it. Another thing that the respiratory system does is it warms the air and makes like a nice aqueous environment, so that because gas exchange doesn't occur very well in a dry environment. And of course, you need air to produce vocal sounds. You also need that semi-moist environment because remember, your olfactory and your smell and your taste require that moist aqueous environment. And we're going to be talking about, which is a big, for all you future RNs, a big topic, which is how exactly does your lungs have anything to do with your pH? Your lungs actually regulate pH. And we got a little bit of a hint of that. When you guys hop on the treadmill in the gym or, you do any workout, what's the first thing you start noticing? You start noticing two things. One, what happens to your breathing? Increase or decrease when you start working out? Increase. So why am I breathing so hard? Well, I need the oxygen, but I'm also have to get rid of the carbon dioxide. And we'll talk about how carbon dioxide kind of links on to the hydrogen ion, because remember what also builds up when you're working out? Lactic acid. And you got to throw some of that out. And one way we throw all that excess acid or all that excess H plus is through breathing. So respiration. So we already talked about external, internal, and cellular respiration. Of course, external respiration, we're talking about what? Your lungs. I inhale oxygen and exhale carbon dioxide. Internal respiration, gas transport. That's when the blood, it's the reason why we have a cardiovascular system. The blood, the red blood cell has to hand off what? Oxygen to whoever, brain, kidney, liver, and then in exchange they get the carbon dioxide. And of course, last but not least, cellular respiration, because I need what? I need oxygen to go inside the cell. I need oxygen to go inside the mitochondria, and then the mitochondria makes me ATP. So that looks like a beautiful question. What's the difference between external, internal, and cellular respiration? External respiration, think what? Ventilation, think lungs. Internal respiration, think gas exchange from your capillaries. And last but not least, cellular respiration. If I mention the cell or mitochondria or ATP, then it's cellular respiration. So you see that gas, oxygen has to come in, carbon dioxide has to go out, but it has to come in and go out on three different levels: your lungs, your blood, and then lastly, of course, your cells. So you could see how there's three opportunities for your gas exchange to go potentially wrong. Now, your entire respiratory system is chopped into two: upper respiratory and lower respiratory. The best way to remember it is that anything from the trachea or windpipe on down is lower respiratory. Everything above that is upper respiratory. And if you look at the upper respiratory, let's say, for example, you have a URTI, which is an upper respiratory tract infection. Is it a big deal? Like if I have a nose, if I have a postnasal drip, am I going to die? How about if I had in my nasal cavities or my sinuses, right? I got a little bit of sinusitis. Remember the little cavities, the holes in my head? If they fill up, am I going to die? No, you feel crappy, but you're not going to die. How about your pharynx? How about if I had pharyngitis? I got a little bit of a sore throat. Am I going to die? No. And how about my larynx? If I had a little laryngitis, and my larynx is my voice box. So if I have laryngitis, I'm also going to have aphonia. And I'm going to talk like Harvey Firestein. Hello, everybody. Welcome to Fire Island. Of course, that's what? Laryngitis and aphonia. No, we're not talking. So all those things that I just mentioned, will you end up in the emergency room for any of those things?
No.
No, right? So that's a URTI, upper respiratory tract infection. Not a biggie. It's really annoying. But the problem is, if that infection goes south or down or inferiorly to my lower respiratory tract, how about if I had tracheitis and my trachea closed up? That's my windpipe. That's the thing. That's the only thing bringing air into my lungs. How much trouble I'm going to be in? A lot. How about my bronchial tree? Anybody here have bronchitis? Right? I'm just coming back from bronchitis just in time for my gout to kick in. Right? So that's not fun. And of course, the lungs itself, pneumonitis. We're gonna, how about what else could affect my lungs? Emphysema, chronic obstructive pulmonary disease. Doesn't these things sound like serious things that will end me up in ER or end me up in a ward? Yes. So if my patient has a lower respiratory tract infection, that's of considerable concern. And now you can see it makes more sense. Things that are in the upper respiratory tract are closer to what? The external outside world. So they're tougher, they can take hits. But things in the lower respiratory tract, like my trachea, my bronchial tree, and my lungs, and I'll show you what those are, or what a bronchial tree looks like. And that's kind of what the tubing in your lungs looks like. It looks like a little tree. You get big tubes, and then it gets little, and smaller branches. So upper respiratory tract, lower respiratory tract, a nice category question, if I do say so myself. Now here is the upper respiratory. And here's the lower respiratory. So this is your trachea, and that's your windpipe. And we already learned the other pipe is what? The esophagus, and that's your food pipe or food tube. Here's the sinuses up here. We already showed that when we were looking at the skeletal system. Remember, what makes your head light? So you can look around and you can see where danger is coming. Well, you got sinuses in your head. And also, the other reason why you got sinuses in your head or holes in your head is because of hearing. High-end speakers kind of look like the inside of your skull. It's because you not only hear through your ears, you also hear through bone conduction. And that's why when you get sinusitis, kind of the real good muffly, right? It's hard to hear things. And also your head feels like what? Feels like a bowling ball. So upper respiratory, yeah, because we want to be careful of that, but it's the lower respiratory. And you can see here, you have your right main stem bronchus and your left main stem bronchus. And then when they get smaller and smaller, those are called your bronchioles. So having bronchitis, which is the inflammation or infection of all these branches, that's not a fun thing. If I had something like emphysema, which we're going to be talking about the alveoli sacs at the end of this, if that fills up, remember, having air is a good thing, but having too much air, like an emphysema, That's a bad thing. And emphysema is like almost 99.9% smokers. What else? You guys heard of pneumonia? Remember, the lungs are supposed to be moist. They can't be wet, right? When the lungs are wet, how well does gas exchange happen? Not very. If the lungs are dry, how well does gas exchange happen? Not very. Lungs have to be what? Moist, not wet, not dry. Question?
What causes pneumonia?
Well, it could be anything. Remember, what are the three things that our body doesn't like? Bacteria, viruses, and foreign body. And we all already know, right? And go, your lymphatic system does what? Doesn't it bring fluid to when you need it? And if you have an inflammatory process, don't you think it's going to start doing what? Filling you up with water. Or let's say your lymphatics are too busy fighting off bacteria, virus, and whatnot, right? And also foreign body. Because what are we breathing in right now, right? Even though we got HEPA filters all up in this joint, right? We can all wear a mask or a level 2 mask. I could wear a bubble on my head, but there's things that I have to breathe in and my lung has to filter that out. Now, if my lung can't handle it, then it's going to start having edema, pulmonary edema. You guys heard of that? That's bad news. You hear that? Woof, we get very, very excited. Yeah. Yeah, it's like anything. Like if I had a cold, what's a cold, right? Just cold symptoms, upper respiratory, right? Remember, if you don't take care of that cold, right, what's going to happen, right? Don't you think you can have a bacterial or because a cold is typically a virus. If you're in a good shape, 7 to 10 days, it should go away. But what if you're immunocompromised? You're a student, you're working too much, you got kids, you got a mortgage. So what's going to happen? Don't you think it's going to get worse, right? You've known me for five, 6 weeks now. You saw it progress right in front of you. It started off as what? You saw me with sniffles, then a little cough. Next thing you know, 3 weeks, I was wheezing. Because why? I'm immunocompromised. Do I sleep well? I try. Do I eat well? I try, right? This job I love this job, but I have businesses that stress me out. Because I have a family that stress me out, just like everybody in the room. So what happens? You don't take care of yourself, and I'll admit, I take care of myself. You saw that it progressed to a lower respiratory tract, and then if I didn't really take care of it and took that 1 day off, do you think I was headed towards pneumonia? You bet. I actually had a fluid level right. My mother listened to my lungs and she's like, oh, she got some fluid level right. That means what? It's starting. So what did I have to do? Take a day off, pretty much put myself in a NyQuil coma, which I don't suggest you guys do, right? But what does sleep do? It heals everything. And it gives your body what? Time, right? So let's talk about nose. We already talked about the nasal septum. Anything that's septum separates your left and your right. Now your nose, your nares, because in Latin we pronounce everything, right? You don't pronounce it nares. It's your nares. Those are the holes. So if I have a lot of mucus, or if I got a cold, don't you think it's going to give me a respiratory problem, even though it's upper, right? Nasal cavity. If we looked at the nasal cavity, let's pan back a little bit. You look at the nasal cavity here. Do you see there's like shelves, right? There's different shelves, and those are your nasal turbinates. Now it's pretty neat because let's say if the top shell gets all gummed up with mucus, I got what? The middle and bottom shells, right? That's why when you blow your nose, of course, right? Like you don't let it. How many of you got kids who do this and then swallow it? It grosses me out. I just always tell my kids, please blow your nose, because what are you doing when you tell your patient to blow your nose? You're clearing out all the mucus that has all the foreign body, all the virus, all the bacteria in it, and then you do what? Throw it out. Older patients are going to have their handkerchief. Guess what? Throw that thing out. That is a point source of infection. My father-in-law is infamous for it, and he just keeps them in his pocket. It's just the nastiest thing, right? But what am I constantly doing? Taking them out of his pocket, washing it, and just pretty much giving him tissues. But those are those nasal turbinates. And you can see here, of course, it's all lined with mucus because what's it going to do? Two things. One, it's warm in there. It's going to make it moist. Two, anything that you're breathing, it's going to get captured in there. Question?
Going back to dealing with patients and blowing their nose. Like I know when I used to work with autistic and mentally,
Yeah. Mhm.
I can't, you know.
Mental defect or dysfunction.
Yeah. We had a lot of patients, especially that used to always
Yeah.
have those sinus infections because they never. moved.
Yeah, they never roll their nose and they're just, they're like children. So they just do this. Ever see your kids do this?
Yeah.
Just like that. And then their hand, their face, and everything they touch becomes a point source of infection. So that's also something to consider. Because let's say, for example, your patient's bedridden. Let's say your patient has what? Mental disease or defect. That's the nice way of saying they don't know how or can't blow their nose. So guess what you got to do? There's this, if you guys ever seen pediatrics and obstetrics, there's a little suction. You know, the little suction? It's part of your job. You got to, all that stuff. And there's also something called wicking. You take a tissue paper and you roll it up and then you stick it in their nose and then you kind of like make a little drill and then you pull it out. It's nasty, but what are you doing? You are getting rid of that excess mucus because if you have an infection, the goblet cells are working overtime. And those turbinates can get what? They can get all gummed up. And if they're all gummed up, how's your olfactory receptors? How are those hair cells? Can you smell anything? No. So that's also not a good thing. And you can see here, here's an exaggerated turbinates here, right? So we try to clear that as much as possible. Now, we're going to be going over to the next thing they're going to be talking about is, well, let me just follow because I'm not skipping ahead. Now, your sinuses, of course. Sinuses are the holes in your skull because remember, your skull is a little sandwich. We already know that from the skeletal system. And we now know why we have sinuses. But they're also, they reduce the weight, they also resonate the voice. That's why when you sing in the shower, you think you deserve what? An award or a record contract. But in reality, what's being projected through your skull is something totally different. And that's why later when I produce this video, I'm gonna go, oh my God, there's that guy. That's what it sounds like to me. That's what my voice sounds like to me. Sounds like that. Sounds very, I don't know, raspy, right? Now, I could have an infection, sinusitis. And of course, if that all gums up, right? How does your head feel? Feels like a bowling ball. How does your voice sound? Sounds awful. Now, those sinuses, can I also have, I could have sinusitis, but since it's a space, don't you think I could have cancers and horrific things in there? Yeah. Now, the pharynx, which is your throat, there are parts to it. And use your medical terminology powers. So the nasopharynx has to be the part of your throat that's connected to what? Your nose. And remember my story, well, he's not really my friend, he was just some kid who sat next to me in lunch. Remember the milk story? Like he could, on demand, like as he's drinking milk, let the milk come out of his nose. Because there's a connection between your throat and your nose. Now, the oropharynx, of course, is a little bit more posterior, and that's what? The oral cavity, and that's, of course, passageway of food and air. And last but not least, the laryngopharynx, that is also your continuous with your throat, and it's more here, the more posterior area, your throat and your laryngeal cartilage, which is your voice box. Now, remember, pharynx, throat, larynx, voice box. Thyroid cartilage. Yep, shoot. Pharynx, throat. Larynx, with an L, voice box. So let's look at the larynx or your voice box. It's made out of a bunch of cartilage. And of course, there's thyroid cartilage that has your Adam's apple. Cricoid, nice to know. But what's the one that we really need to know out of the cartilages of our larynx? We need to know the epiglottis. And we've already seen the epiglottis in our GI lecture last Friday. The epiglottis is that little cartilaginous flap that closes when I eat or drink. Because when I eat or drink, should I be breathing?
No.
No. And we all know that if some fluid or some food gets into my windpipe, my trachea, what happens? I have a gag reflex and I'll start what? Choking. So out of these three, nice to know Adam's apple, nice to know that there's a floating cricoid cartilage. But the one thing about your larynx the piece of cartilage that's really important is that epiglottis. That's the thing that's going to close down. It's going to be the protective flap of my trachea so that food or water doesn't get in there.
And the thyrax, so that you're the epiglottis for the lyrax, whether the thyrax, do you want us to know all the other three portions?
What's thyrax? Wait, hold on. Let's go back.
I mean, thyroid.
No.
Thyrax, sorry.
We didn't. No, the thyroid and cricoid, nice to know. Epiglottis, must know. So think what? Because what's so important about the cartilage in your larynx or your voice box? The most important part is your epiglottis, because that's the thing that's going to close down your trachea so that when you eat or drink, no food or drink gets into your lungs. Because anyone know what well, no. You know what? I promised myself not talk about pathologies, only normal stuff. But just know there's a reason why I tube you when you go to surgery. I got to put a tube in you because do I want anything from the outside world ending up in your lung?
No.
No, because you're going to get a certain type of pneumonia, which is extra nasty. All right. And it's very hard to manage. Right. Now, let's talk about vocal cords. Now, you have false ones and true ones. Nice to know. Just know that there's two pairs of vocal cords, and also know that air is required. So any of you who are singers in the room, you guys know that like when you are in choir or when you're singing, what do you got to do? Always breathe. Always do your breathing exercises and your vocalizations. And vocal cords, since they are connective tissue, can they be broken?
Yes.
Yes. Can they be destroyed? Yes. So people who are professional singers and whatnot, if you ever look at tour dates, there's certain breaks there for a reason. Because can a singer keep on doing the same thing all night, every night?
No.
No. And also, especially if they're the lead singer, especially if it's like a lot of money involved, even if there's not a lot of money involved, they're not allowed to talk. They're always rapping. There's always rapping their throat, right? And they're always mindful of upper respiratory tract infections. So you can see the vocal cords here. They kind of work like a guitar, and everyone's seen a guitar, right?
Mm-hmm.
If you strum the guitar on an open string, it'll vibrate, and that's what causes sound. But what happens if there's infection, cancer, or whatnot? It's the same thing as putting your hand across the strings of guitar. If I put the hands across the strings of my guitar, will I hear the guitar strum? No, it'll be muffled. So that's why you need air. That's why these things have to be nice, wide, and open. Question? No. Your glottis is the posterior portion of your larynx, but it is the epiglottis. Epi means what? On top of. So think epi, it's going to be a flap, a cartilaginous flap that's going to go on top of my trachea to protect it.
Should we know the difference or
No.
like only focus on
No, just epiglottis because that's really important. Because that is also a very important landmark when you guys one day learn how to tube somebody. Now, trachea, that's your windpipe. What's important about the trachea is if you look there on the fourth or fifth bullet, it has C-shaped cartilaginous rings. Now, we already know that cartilage is like semi-flexible, but it's also like kind of like bone, it's protected. So if you look at the C shape, right? Don't you see here? That's also why I miss working on like actual piggies. So like when we cut up the pigs, you can really feel it. On the anatomage, it's hard to see. But let's say this is the C-shaped cartilage, right? And it's here. Isn't it cool how it's protecting you from the front?
Yeah.
But in the back, it doesn't constrict you. So that makes sense because if I swallow something really, really big, it still allows my esophagus to expand. So that's C-shaped hyaline cartilage. And of course, use your medical terminology powers. If if everything in my upper respiratory tract, I already told you, this particular patient, remember the bus, wasn't a bus driver, it was, she was a truck driver. And, trucks, they're hefty, they're not made out of plastic, everything's with steel. Well, she had blunt force trauma, meaning she hit her face and chest on the steering wheel and the dash. That's how fast she was going when she hit like one of these retaining walls. Well, all her teeth and some of her mandible and maxilla ended up in her throat. So was she breathing? No. So when me and Julio got to her, she was what? Struggling. There's barely any air getting in. So what did we need to perform? Right? And as EMT deltas, you call it in, and then the emergency medicine physician talks you through it. But we already done multiple simulations, and we're trained to do a tracheostomy. When you look at the word stomy, I am creating a stoma. I'm creating a hole in the trachea, in between the cartilaginous rings, and then what do? I put a tube in there, right? So that's called a tracheostomy, because she had nothing up here. This was essentially what? Like she took a sledgehammer, went like that, and all her teeth pretty much fell into her oropharynx and her pharyngeal cavity here. I even found teeth in her larynx when I was trying to clean some of that stuff out, because I was trying to do a blind sweep to tube her down. But of course, when your face gets all smashed up like that, don't you think there's going to be inflammation? So all of that, her tongue swelled up, everything was like what? Well, what was left of her tongue, because she bit some of it off when she hit the steering wheel. But all this was hamburger. So she's like, oh, she can't breathe, right? Called it in. They said, go, right? E-trach, and we did our business. That was the, I only did that like 2 or 3 times in my career, but I was super nervous, and I was like, when I was done, I was like, got to do surgery. So when we look at this picture. This is a little bit, of course, the larynx is part of our upper respiratory tract, but it's starting cartilage, right? Now you look at the trachea, then you have your right stem bronchus and your left stem bronchus, and we're going to talk, and that bifurcation, which is a fancy word for crossroad, that bifurcation where the trachea splits off into a right and left main bronchus is called your carina, right here. And of course, you got a lung here, right lung and left lung. And one thing you'll notice is you look at the bronchus, it's going to start branching off like a tree. So it's going to have branches that get smaller and smaller and smaller. And this is what your, well, from here on down, your trachea on down, that's what your lower respiratory tract looks like. Remember, your larynx is part of your what? Upper respiratory tract. So if I lose my voice because I got a little bit of a cold, will I die? No. But if that trachea, which is the only tube that leads into my lungs, starts closing off for whatever reason, am I in a lot of trouble? Yes. So we already know that you got the right main stem bronchus and the left. Well, let's go back because I want to show you. Do you guys notice how the right is like bigger, a little bit bigger, and it's steep?
Mhm.
It's almost connected to the tree. So when you think about it, anything that falls into my trachea, like dust or dirt or rocks or whatever that might go in there, like, don't you think it's going to end up in the right quicker than it's going to end up in the left?
Mhm.
Just because, look at the shape of the right. It's fatter and it's like more direct. But if you look at the left one, it's a little bit smaller and it's what? It's more, it's less angled. Foreign body, maybe you heard of asbestosis and coal miner's lung, which is pneumoconiosis. You see those commercials, on TV, right? Nowadays it's a rarity, but don't you think dust and dirt debris do the same thing? And same thing also, smoke inhalation as well. Don't you know when you got smoke inhalation? It's those particles. By the way, you don't die in a fire because of the heat of the fire.
Smoke,
You die
smoke.
way before that, right? So, nice investment. And gas masks nowadays, they're not that expensive. And, but, you know, what's better, how's this? Just have not a fire in your house. So that is your lungs. That's your right, why am I pointing at it like you see it? This is your right main stem bronchus, and this is your left main stem bronchus, and then they all break down into bronchioles. I'm going to show you a second. Shoot,
I
question.
just wanted to like see if it was on topic to talk about collapsed lungs.
Well, we're gonna, yeah, it is. Wait for it.
Okay.
I'm going to talk about pressures. What keeps your lung open?
Okay.
But right now, we're only looking at structures. So if you look at the very, very ends of the bronchioles, do you notice that the bronchus gets smaller and smaller and smaller until it gets to like what? Bronchioles. Anything ol or ule means what? Tiny. So an arteriole is a tiny artery. A venule is a tiny vein. Well, a bronchiole or a terminal bronchiole is a tiny bronchus. Now, the one thing you notice, why am I pointing at that? I should be pointing at this because this is recorded. If you notice up here, there's a lot of cartilage, isn't it? But do you see that the cartilage starts disappearing the deeper you get in your lung? And what does it replace itself with? And you'll see here, it starts replacing itself with smooth muscle. So do I have all the asthmatics in the room, do I have any control over that muscle? No. So if my lungs feel like it's what? It's being attacked, what do you think those smooth muscles going to do? It's going to close. And for us asthmatics in the room, I got bronchitis. Asthma is something different. But asthma is kind of like an exaggerated immune response, right? So the asthmatic, not on any medication, gets exposed to a lot of dust or foreign body. What's those bronchioles going to do? It's
Closed.
going to close up. Now, everything that wheezes in your lung isn't asthma. But can you see now why that asthmatics, some of them wheeze? Because if that bronchiole starts closing up, it's just like your mouth, right? Right? Once it starts closing up, it's going to start making a sound, right? But again, clinically, not everything that wheezes is asthma, but you can actually see where wheezing comes from when these passageways start getting closed up. Now, you'll also see, of course, there's a lot of arteries and veins in there, and it makes sense. I got to have gas exchange. Remember our pulmonary artery? It's bringing that deoxygenated blood into a whole bunch of other blood vessels so that when I breathe in, I'm breathing in oxygen and I'm breathing out carbon dioxide. Now, where does all the magic happen? And if you can see here, it looks like at the end of these terminal bronchioles, it looks like a bunch of grapes. In Latin, bunches of grapes, the term for that is alveoli. So these alveoli, these bunches of grapes, that's where the sacs of air, that's where the gas exchange occurs, along with all these little capillaries. And again, can that area be dry? No. Can that area be wet? No. That area must be what? Moist, in the middle. So to answer the pneumonia question, if water starts building up in this bottom section, right, and then starts filling up my lung, how's the gas exchange? Right? Not very good. Try it. Go breathe in the water. See how well that works. Right? It doesn't do very well. And also, anyone ever here been in a desert for an extended amount of time? Right? If you didn't have any water, how well is your breathing? It gets very difficult, even at sea level. Last time I went hiking at Red Rock in Vegas, it was late spring, and you know Vegas is what, hotter than the sun, right? So it was like what, 90 something, but it wasn't really the temperature. You know how they say in Texas it's a dry heat? No, it's a heat. That heat, no, it goes, and also the dry arid desert. What were we doing at the end of the day? We're all coughing, and that desert, doesn't it have a lot of dust, and you're sucking that all in? I was wondering, because I was wondering why all the motorcycle people who were there, it's, Red Rock is really cool. It has hikers, has nature people, and it also has a whole bunch of, drunk motorcycle people, which I kind of gravitated to. They were nice guys, right? Why they were wearing their masks all day? And it was pre-COVID, and I'm like, now I look at it, makes total sense. I'm in the desert. These things need to do what? Gas exchange. So your alveoli, now you know why the lower respiratory tract is very important. The alveoli, along with all the capillaries, are the point source of the gas exchange. So if anything happens bad deep in my lungs, any lower respiratory tract infection, pneumonia, and COPD, heard of that. That's chronic obstructive pulmonary disease. That's emphysema and bronchitis. Any of that stuff down there, I'm even coughing thinking about it. Anything that's down there is going to give that gas exchange a really hard time. So think alveoli and so the bunches of grapes, alveoli and its associated capillaries, pulmonary capillaries, that is the main source of what? The gas exchange. That's where I have to take in all the oxygen and then do what with the carbon dioxide. So now this has to be Illuminati stuff to you guys, because we started out week one going, why do I have to look at this chemistry? Why do we have to memorize that oxygen goes in, carbon dioxide goes out? Because oxygen goes in, water goes out. Because also when I'm doing what? Don't you think water vapor is coming out too? Because this whole system, is it wet? No, it's moist. Now, alveoli, gas exchange, right? Now when we look at it, now you're gonna see pressures and things like that. Don't fret, because you don't have to memorize it. But we all know, why does oxygen come in? Think about it. Your pulmonary artery, is it oxygenated or deoxygenated? Deoxygenated. So what's the pressure of oxygen in the blood coming into my lungs? It's gonna be down or low, right? So what do I do when I breathe? I'm taking in oxygen. There's gonna be what? A ton of oxygen in my lungs, at higher pressure than my what? My blood. So where's the oxygen gonna go? Remember diffusion? It's gonna go through a semi-permeable membrane, which is this alveoli, and then it's gonna go where? Right into these capillaries, because it's coming from an area of high pressure to low pressure. Don't you think when we put people on mechanical ventilation, we do that? We kind of do that artificially? Or maybe you guys heard of people who get hurt diving. We put them in an iron lung, and we're doing that what? We're changing the pressures on purpose so that the pressure of oxygen is higher where? On the outside than it's on the inside. So then what will it do? We'll go in. Now let's look at the opposite side. When I'm holding my breath, what's building up? Carbon dioxide, isn't it? Building. So now the carbon dioxide in my lungs are what? Higher or lower? Higher. So now what's it going to force my lungs to do? Blow out. So that's stuff that we talked about, from a high concentration to a low concentration. When we talked about tonicity, we can also talk about the pressures of gases. So gases work in the same way as solutes. So if you have a high amount of gas over here, it's going to want to do what? Go to the low area. If you have a high amount of gas over here, then it's going to want to go where? To the low area. And the neat part is oxygen and carbon dioxide don't mix. Oxygen we take in, carbon dioxide we get rid of. And you can see here, because oxygen will go where? Into the blue, right? And and CO2 will come out of the blue. Now that makes sense. Now, of course, long question. What's your hilum? Oh, I'll show you that in a minute. It's better if I just show you. But we already know about the pleura. We knew that about since chapter 3. And of course, we already know it has a visceral and a parietal, right? And we already know that the viscera is the deeper one. The parietal one is the one most on top. And we also already know, because we've seen other structures similar to it, that there's a pleural cavity, a potential space in between the visceral and parietal area. And what's it filled with? Serous fluid. Sound familiar? Sounds just like the pericardium, sounds just like the peritoneum, because it is. Because the lungs, all day, every day, what's it doing? Expanding, contracting, expanding, contracting. So you don't want it to, create friction, because friction creates heat, heat creates pain, that's not fun. But all of us who've had a bad cold experience pleurisy. And pleurisy is when that fluid gets infected with pus or blood or heaven knows what, right? Have you ever had a bad cough where it feels like there's a knife rubbing on your breastbone or your sternum? That's pleurisy. That's because what is now happening? That pleural cavity is now no longer has nice, clean, serous fluid. It probably has like pus or bacteria or virus in it. So pleura, no one should get that wrong, because we've seen that question. Which is the most inner layer? Visceral. Which is the most outer layer? Parietal. And what's in between? Some sort of serous lubrication fluid. I'll get to the hilum in a moment. Now, you could also see, just like your cardiovascular system, right? It's protected. And also now we recall that our lungs are protected by these bones called our ribs, but we already recall that the ribs also have cartilage. And remember, your joint lecture, isn't that amphiarthrotic?
Yes.
Right? So your chest cavity has to move a little bit, not a lot, but a little bit. And if I have chondritis, how much trouble I'm in? Question.
Can you repeat what was the last one again?
Your lungs are protected just like your cardiovascular.
In the page before.
Okay. Visceral, parietal, and pleural cavity. Remember, that's a layers question, right? Viscera is always your deep or superficial. It's always what? Your guts. And where are your guts? They're deep, right? So think visceral, deeper layer. Parietal, think what? The other one, which is on top. And what's always in the middle between viscera and parietal layers? A slippery lubricant, serous fluid. And if any of that fluid gets messed up or gets contaminated, then you're going to have some problems. Now, this part, of course, lungs, you're covered by your ribs and cartilage, and your cartilage has to move a little bit. And you can look at the lung when you have this. Oh, by the way, what section is this? Transverse, right? So if I'm looking at a CT transverse of my lung, this is the picture you better be bringing me, because then it shows me what? It shows me, look, shows me my chambers of my heart, shows me my esophagus, my descending aorta, right? So this has to be the front, this has to be the back. But this shows you also how we're going to be talking about how the lung has little separations, has little rooms. If ever you watch the movie Titanic, right? Titanic, they talked about the baffles. They talked about these big rooms so that if one gets flooded, the other ones don't get flooded. Well, whoever built us pretty smart. They built lobes so that if one gets cancer, does the whole lung need to get cancer? If one lobe gets bronchitis, does the whole lung need to get bronchitis? Right? And that's why you can also do lobectomies in pulmonary surgery, because let's say if I had a really bad part of my lung, I could cut that part out and then my patient still can breathe. So you could also see here that the pericardium has the double layer. The pleura also has that double layer. And in between both double layers is that serous fluid, because all of this is moving all the time. Breathing, ventilation, inspiration, expiration, and of course it's a respiratory cycle. It never ends. Now, you need to know this. No, I don't want you to know this, because this is other stuff. I just want you to know, let's see. All right, I'll do it this way. Again, don't memorize pressures. So let me show you a picture. Well, I'm gonna draw a picture of inspiration and expiration. If my mouse will cooperate. Draw.
Do not memorize or do not worry about pressures.
Yeah, because
So boils.
you guys aren't taking NCLEX yet, so forget about
Okay.
boils. But you need to know how you breathe. This is me. Okay. Now, there's atmospheric pressure and there's of course internal pressure. So the way you breathe is like this. We already know that gases move from an area of high concentration to an area of low concentration. And there's this thin muscle, right, in your abdomen called your diaphragm, right? Now that thin muscle that separates your abdominal cavity and your chest cavity, when you're breathing, this diaphragm is going to start going down. Now, the reason why they showed you guys a syringe in the previous picture is because when that diaphragm goes down, did you ever wonder, like when you have a syringe, when you pull up the plunger on the syringe, water then goes what?
Down.
Goes, well, no, goes
Oh, well.
up into the syringe. Well, guess what? If my diaphragm moves down, it's going to create a negative pressure. Now, if my atmospheric pressure of course is positive, where's air going to go?
Yeah.
It's going to go, that's an arrow. So this is inhalation. So in order for you to breathe, you need your diaphragm. Your diaphragm will bottom out. Your chest cavity will do what when you inhale? You notice your chest cavity will go up and out. And just like the syringe, it's going to create a negative pressure. And then what's it going to do? Air is now going to go in my lungs. Well, if I keep on going, right? There's only so much space, right? So what's going to happen? Now, isn't there going to be a buildup of pressure here?
Mhm.
So let's use this one. This is me. Now, when I inhaled as much as I could, now the pressure in my lungs are now what?
Positive.
Positive.
Meaning-
Much greater than, and I'm going to draw up P atmospheric, like a little.
Meaning like.
It's
filled.
much smaller. So what's going to happen when the pressure in my lungs gets greater? Then my patient will what? Exhale. And this is exactly what we do when we hook the patient up to a mechanical ventilator. We change the pressures so that my patient can what? Well, the machine does what? Inhale and then exhale for my patient. And the neat thing about mechanical ventilation is that I can what? Control it, right? Questions?
So what about those patients that have to have those nasal cavity around their face? And they have
Oh,
to-
like, no, that's called a cannula.
Yeah.
Now, I don't like the nasal cannula, the little nose thing,
Right.
because number one, patients don't like it.
They know.
And number two, also, here's the thing with pulmo. They're not gonna like anything because the very fact that they're not breathing. Because also, if you guys ever had per mask, that's not fun either. Even though there's 5 liters of oxygen flowing through it, I've been in the hospital in pulmo more than once in my life. You still feel like you can't breathe, right?
Mhm.
Even though my mind is already looking at the gauge and I'm trying to trust the pulmonologist and the nurses as much as I can, but I don't know, I just feel stifled. Just know that your patient, when they're having a hard time breathing, we can supplement their oxygen that way, put a nasal cannula, or we can put per mask. Another thing that you see in hospitals we also do is we put the mask I juice it up to 5 liters, but I just leave the mask off kilter a
Yeah,
little bit,
yeah.
so the patient can at least like, especially if they vomit, because vomiting with the mask is just nasty, and it's just hard, and again, I don't want any aspirational pneumonia, and that's a problem. So, he goes, when you see how you breathe, inhalation, what does the first thing that has to happen? Your diaphragm has to do what? Contract, which will drop what? Down. Then it'll create a negative pressure in your lungs so that my patient will now what? Inhale. Once the pressure is, builds up and is great enough, greater than atmospheric pressure, then what will my patient now do? Exhale. For future RN training, there are, knowing and understanding this diagrammatically will help you memorize lung pressures. Because you're like, once they talk about TOR and 760 atmospheres and stuff like that, that's when it starts getting confusing. But know this at this level, if you know that your lung is creating a negative pressure, think what? Inhalation. Positive pressure, exhalation. Question.
With the plus sign, it's not.
P atmospheric.
So negative is what is it called? Say it one more time.
Negative pressure, right?
Yeah.
Is inhalation. Let's write inhalation here.
Thank you.
More memorable.
What about like CPAP machines? Because they blow,
So what's CPAP mean?
is it kind of like you don't breathe?
No, look, no, think of what, inhalation. Think of what CPAP means. It means what? Continuous, positive,
Pressure.
airway pressure.
Okay,
So what's it doing? Right? It's now doing what?
forcing air.
This. Right?
Oh.
And so inhalation and, let's insert.
Oh wait, so I thought the CPAP blows air in.
Yeah, and what's it doing? It's creating a positive pressure.
Oh, so that you're exhaling.
So it forces me then to do what? Exhale.
Okay.
Because what's the problem with, why does a patient have to, have the CPAP?
They stop breathing in their sleep.
Yeah, they could have, well, it's several things. Insulation. So you look at this, right? Now, just as a side note, not for exam. So when you're thinking about CPAP, means what? Continuous positive airway pressure. So what's it kind of pushing? It's pushing the air in. So it pushes the air in, it'll increase the positive pressure inside the lung, and then what's the patient gonna do? Exhale, and then the cycle does what? Starts all over again. And also, another thing that a lot of CPAP machines do is, what's it doing? It also filters whatever, because let's say, for example, my patient has too much mucus, or my patient has some sort of septal defect or some defect here in the pharynx. One of the defects is that, all the musculature in the pharynx and larynx kind of close up. So, yeah, my nephew, for whatever reason, his saliva builds up and he chokes in the middle of the night. So he has to not only have the CPAP machine, he's gotta he can't sleep flat. He's gotta sleep on an angle in like this cushion that pulmonary med gave him, because he was having sleeping difficulties. And then when they did a sleep study, they found out it wasn't neurologic, it was what? Respiratory. And then so that has a nice, and a little side note regarding CPAP machines, they get really yucky, really
Yes, you have
nasty
to
quickly.
clean them.
So clean daily. And if you can afford, or your patient should be able to afford it, because it's part and parcel of their
Insurance.
management and insurance, assuming they have insurance. There's these nice little UV boxes that they get. You not only have to wipe it all down, you put it in the UV box, you set it, forget it, so that when you take it again, the next evening, it should be up and running. Question?
What about iron lungs? Like, you have.
Iron lung is the same thing,
It's a
right?
diaphragm,
Oh,
right?
why did I get rid of it? It's the same thing. Why do I need an iron lung?
It acts as a diaphragm.
Yeah, well, it acts like, because
Provides
what, because,
pressure.
no, just think about what's the classic reason why I need an iron lung? Where have we seen that before in movies?
We deal with people who have water.
Yeah, so it's called Caisson's disease. When you go, anyone, oh no, that's right, this class doesn't go diving, doesn't jump out of airplanes. I'm the only one,
It's just-
all right? All right, so Caisson's disease, remember, how's the pressure, atmospheric pressure versus the pressure 20, 30 feet underwater? It's very different. And the mixture of gases, especially nitrogen and oxygen, are very different down there, right? So what happens? Bubbles get to form in your lungs. And do we need bubble? Do I need an embolus in the shape of what? Oxygen floating around my capillaries?
No.
No, so don't you think that bubble, once you get up to atmospheric pressure, the bubble will expand and then close off my arteries. And then you have yourself a nice little stroke. And that's what Caisson's disease is. Now, how do I prevent that? Let's say my patient came up too fast, right? We immediately bring them to the emergency room. You got pretty much like 45 minutes to about an hour, so don't quote me on it. But last time I remember my email, you put them in an iron lung. And what's an iron lung? It's like you put them in this big tube, right? And what do? We mess with the pressures inside that tube, and then we slowly bring those pressures back up. And so if you ever go diving, make sure, you actually pay attention when you're in class, because when they talk about mixing the gas and all that stuff, right, it's important. And also, don't go to, especially if you go to a resort or whatever, go to one that's, what's it, IAPD certified. Make sure they're certified, make sure the equipment looks good. Man, last time I went to Mexico, the equipment was like all rusty and all that stuff. So what happened to me when I got back up? I got sick. Because did they clean out the mask? Did they clean everything? No. And you're breathing that stuff.
Wait, so an air bubble can be a clot?
Yep, an air bubble can be an embolus, can it? Yeah, if I have a big enough, that's why if I took a syringe filled with air and I put it right here in your neck, and then I put a bubble of air in your carotid, what's it gonna do? That bubble's gonna go where? Up in my brain and then what? Stop everything. Because how's air? Air is usually what? I mean, oxygen is usually diffused inside blood, sitting on my hemoglobin. But if I injected it into your neck, please don't try that at home, right? If I inject it into your neck, what do I got? I don't have dissolved gas. I have what? An actual bubble that's going to float around. And that's kind of scary.
Is there an amount, like as if we're a nurse is doing lines, like? is
No.
it like
When you do your
zero?
line, right, there's protocols in play. And you ever see when they do it, when they're like tapping?
Yeah.
That's why you're tapping the needle. You're putting the needle upward so that all the bubbles go out top. And that's why, let's say you want to load 5 cc's. You'll load a little bit more than 5 cc's, tap, get the air out, and then what? It brings the measurement to 5 cc's. And you'll learn all of that when you're in your clinical stuff. So when you look at this thing here, now you know what your lungs, and this is a main lung. Now, what's the other main muscle in your lung? We already now talked about your diaphragm. Do you see these little muscles in between your ribs? Those are your intercostal muscles. So they too will do what?
Expand.
Expand your chest up and out so that you can inhale. So what are the two muscles that are really important for breathing, for regular, normal breathing? And those are your diaphragm and your intercostal muscles. Doesn't that sound like a beautiful both Avian
Yeah.
question?
So the intercostal,
Yeah, shoot. Your question, then your question.
there is the.
Is this one right here? They're inter
Oh,
means
the red,
between,
kind of like candy cane.
Yeah. right? They're in between my what? My ribs, hence the term intercostal. Now, if I have a muscle problem, like myasthenia gravis, how's my breathing? It's in trouble, isn't it? So now you see, you have the skeletal muscle, right? Because I can control these things, right? Is important in breathing. And notice, I only mentioned, the diaphragm in inhalation. What should exhalation be? When you exhale, it should be what? Passive.
Relaxed.
I'm not physically doing this every time I exhale, but I'm physically doing what? Inhaling, but then I do what? You just let go.
Mhm.
And it should be like from 1 to 3. Like, so takes like, I don't know, like 1 beat to inhale. It should take what? That's a little bit longer to exhale. So think inhalation, the two important muscles is the diaphragm and your intercostals. Now, let's say my patient's in trouble. They have asthma, they have whatnot. Don't you think they start hunching over
Yes.
and they start using what? Other muscles, like their shoulders, right? You guys saw me week 1, week 2, when it was really bad. What was I doing? I was like leaning like this, and then what? Where did you see my shoulders when I'm breathing?
No.
They were moving. Because why? Not enough air is coming in. The intercostals and the diaphragm ain't cutting it. I need what? A little bit more oomph. So what will happen? The accessory muscles start kicking in. So just know that two main muscles are your diaphragm and your intercostals. Anything else that your patient starts breathing and their posture starts changing, then you know they're starting, it looks like dyspnea. So inspiration, of course, normal resting, we talked about that. And then, yeah, you can force inspiration, but you can actually force anything because these are skeletal muscles we're playing with. And you can see how your chest actually moves up and out. And it's kind of like like a handle on a pail. If you ever see a handle on a pail, when you move it up and down, it moves what? Out and up. And that's the normal position of your thoracic cage when you are breathing. Now,
So don't worry about inspiration or expiration.
yeah, you need to know what inspiration is. And you need to
Okay.
know what expiration is.
So,
Now, how is it that on expiration it's passive? Like I don't physically have to blow out on expiration. Well, because we already know that muscles are what? And all the tissue that are in my cartilage are flexible to an extent. So there's some level of elastic recall. Now, another thing, I mentioned the alveoli has to be moist. It can't be dry, it can't be wet. It has to be moist. Now, another reason why moist, and the actual definitive physiologic reason is water has surface tension. Now, what does that mean? If you've ever seen, has any of you ever seen a mosquito on a drop of water? Maybe it was a rainy summer day, and you watch a mosquito or whatever gnat or just sit on top of water,
Yes.
and you saw the water didn't break,
Yeah.
right? And that's the why water beads out. Now, water beads up that way, and that's because of surface tension. And you need that surface tension. Surface tension is required for gases to go in and out. Because if the water just collapsed, then what? Water would just be flat. There wouldn't be like a skin to go in and out. Does that make any sense? Just know that if you don't get that, just know that surface tension is required for gas exchange. And where does gas exchange occur? It occurs in our alveoli. And that's important because there's a chemical called surfactant. It's the reason why we get very excited when babies are premature. Now, to laypersons think preemies are cute. Oh, we're gonna have a birthday early. No, preemies are dangerous because even 1 week we don't like, because we like 40 weeks age of gestation. I don't like more, I don't like less. But when it starts getting into 36, 35, 30 weeks, then that's when we have to put the baby on an incubator. That's why we have to put the baby on mechanical ventilation, because baby doesn't have surfactant and baby won't have surface tension. If a baby doesn't have surface tension or this chemical called surfactant, and I believe that I'm mentioning in future slides, then if there's no surface tension, can gas go in and out? No, it can't. And that's why we don't like preemies. And that's why premature babies, 9 times out of 10 have some sort of respiratory problem. And that's why you do the APGAR score, and you learn all of that. In obstetrics, question.
So what causes a burp?
A what?
A burp? You know, like if you burp or something?
Oh, well, we already know.
Digestion.
We already talked about it in gastrointestinal, right?
Okay, so,
It's
yeah.
the same thing that causes farts or flatus, right? Of course, we have acids, right? The acid reacts to the food and whatnot and creates gas. Now, Burping also, for pediatrics as well, you could have aerophagia. Aero means air. Phagia means what? Eat. Because some babies, when they breathe like what? Like that, like they're eating air. That's okay, that's normal. But then if I'm taking excess amount of gas, don't you think I could get some of that in my GI?
Yeah.
Especially baby, all the epiglottis and all that stuff isn't that coordinated. So then what do you get? That's why when babies get a little bit tympanic stomach, right? And then they'll do what? They get gassy and they get cranky. We already know why gas is built up. And we have sphincters and pockets, and gas can get all trapped up in there. Now, this slide, should I teach this? Well, of course, don't memorize any numbers or any of that. I don't like this. This is a better picture. Let me show this picture. What do you mean App Store? I don't want to. Okay. Why does it want? Let me. A moment. I'm having some technical difficulty. There you go. So let's look at this. This is the easier way to look at it. And then we'll call it a break. Or
I've done with those.
yeah, those are fun. Oh, these are not fun. Ugh. Thank goodness I don't have
What,
to
just
keep-
reading them, graphing them?
No, interpreting them.
Oh.
Easy. It's relatively easy to do that machine. It's the interpretation.
Mhm.
So well, let's look at this. This is like a graphical representation of this picture. I don't like words. You guys know that. I like what?
Pictures.
Like pictures. And this picture is much, much better. Let me see if I can make it bigger. This picture is much better. So your lung has maximum 6 liters or so,
Mhm.
give or take. So what do you need to know? Like if you see this, where it's going up and down, that's your tidal volume. Like a wave, you inspire, expire, inspire, expire. And if you're just resting, it's barely 500 cc's or half a liter of you just breathing. And that's called your tidal volume. Now, if that machine that we just showed you, if I made you inhale as much as you possibly can, above your normal breathing, you say inhale, more, more, more. That is your inspiratory reserve volume, or your IRV, right? And of course, tidal volume, TV, everything. Now, expiratory reserve volume, let's say I'm breathing normally, and then I ask you, exhale all the air in your lungs. More, more. Until what? I got nothing left. In reality, you have water. You got about a liter left. So inspiratory reserve volume is as much as I can do what? Inhale. Expiratory reserve volume is much as I can exhale. Tidal volume is just me regularly breathing. Question? Yeah, because what's a spirometer? Spiro means to breathe.
Mhm.
Meter is to measure. And we do spirometer for a whole bunch of things. Not all, but in surgery, it usually, because what happens when why am I doing surgery stuff? You guys aren't going to be surgeons yet. How's this? Let's go back to this. Tidal volume, me just breathing. There. Inspiratory reserve volume, the maximum amount that you can do what? Inhale. Expiratory reserve volume, the maximum amount you can what? Exhale. But what's this residual volume? At any given time, there's always about a liter worth of space in your lung. Okay? Now, if you know the IRV, TV, ERV, and RV, which is inspiratory reserve volume, up here, tidal volume, TV, expiratory reserve volume, ERV, RV, residual volume. Do you think now you can do the math? So if we measure the inspiratory capacity of my patient, that's what? IRV plus TV, right? You could see how it's like this yellow and this pink, and that's your inspiratory capacity. And your FRC, which is your functional residual capacity, that's your what? Expiratory reserve volume plus your residual volume. Now, goes, what's your vital capacity? Is what you need vital. Al pertain to beta. In Espanol, vida, life, right? So your vital capacity is what? Your IRV plus TV plus ERV. And residual volume is always what? The purple, the extra. And total lung capacity is your tidal volume plus your, total lung capacity, of course, is what? Everything, isn't it? So in the future, if ever you're going to take the NCLEX, you're going to have to memorize these lung volumes, and you're going to have to memorize, IRV is IRV plus TV and all that. But for this exam, for this quiz, what do you need to know? I could ask you, what's tidal volume? And you'll tell me what? Just breathing. Just breathing day to day. Inhale, exhale. Not doing anything special. I could ask you, what's inspiratory reserve volume? That's as much as I can what?
Breathe in.
Inspiration. Much as I can inhale, as much as I can. And what's as much as I can exhale?
Expiratory.
Expiratory reserve volume. That's the worst I'll do to you.
So no.
So no TV, ERV, IRV, also known as inspiratory reserve volume, tidal volume, and expiratory reserve volume. But just know that these other things exist in the world. And for some of you with aspirations of RN and NCLEX, know that one day you're going to have to memorize that chart and the numbers associated with it, and the pathologies, what the pathologies do to each one of these numbers. Question?
You didn't know about the capacity?
Nope. So this stuff, for your edification, nice Charlie question, but what's an alpha question? What's a must know? Do I know what my inspiratory reserve volume is? And you don't need to know the numbers. It's how much I can what? Inhale. Tidal volume, how much me normally breathing. And expiratory reserve volume, how much I can, what's the maximum I can exhale. And that's the worst I'll do to you. All right, with that being said, let's go back to your chart. And you can see why I like pictures way better than, how many minutes I got? I got 3, so I got room for one more
what picture?
One more idea,
Okay.
one more slide. So let's talk about anatomic dead space. Now, the reason why we kind of don't care about the upper respiratory tract is because why? It's considered part of your anatomic dead space. That means there's no gas exchange. Where's the only place that gas exchange occurs? In the alveoli, right? So that's the most critical. So do I really care what's going on in my nasal, my nasal passages, my sinus, and my throat? Not really. And hence, that's why they call it anatomic dead space. But of course, we know that if I block any of that, I'm going to have trouble breathing. Now, alveolar dead space, right? That's the dead space. Think dead space is what? Anything that doesn't contribute to gas exchange. So physiologic dead space, alveolar dead space, anatomic dead space. It just means what? Is there gas exchange going on in these places? And your answer will always be no. Is there gas exchange going on in anatomic dead space? No. Is there gas exchange going on in the alveolar dead space? No. Is there gas exchange going on in the physiologic dead space, which is the anatomic plus the alveolar? No. So what's the most important part or critical part of gas exchange is your alveoli. And that's what this thing is talking about. How could I ask the question? I could just, if you see dead space, that means what? Is any gas exchange going on? No. And it's like a kind of a negative question. So with that being said, let me pause my recording so I don't have to do